Right, good morning. I come from UCL, and actually, this morning's actually been quite focused on atrial fibrillation. I thought it would be quite pertinent to mention Thomas Lewis, who first described the ECG and AF and its correlates with cardiovascular physiology. And he made this interesting statement. At the age of 45, a change takes place in the cerebral vessels. They become more rigid, and perhaps as a consequence, ideas become more fixed. You will find it very difficult to get a man over 45 to listen to new ideas. Now, I'm not sure if Shiv is over 45, but there are many grey hairs in this room, and I think the great thing about this meeting is the first meeting I've been for a long time where actually there is no dogma because we don't really understand what we're talking about yet. We have some tools to investigate physiology, but it's really very much black box medicine. And I think this is something that we've probably got the next 20, 30 years to explore. And it's quite exciting particularly because in EP, everyone's become very focused on ablation and one target in the substrate. Now, I'm starting with this slide deliberately because I want to tell you that I actually do know something about ion channel disorders. And we've known for the past 20 or 30 years that the genetic basis of a number of these conditions, long QT, I just updated this yesterday, there are now 15 genes responsible for long QT syndrome, at least 6 or 7 genes associated with Brugada syndrome, and we have short QT and idiopathic VF. The point here is that we focus very much on ion channelopathy in the substrate. When we come to looking at our understanding of autonomic physiology, you couldn't get a simpler slide than this for its relationship with ion channel disease. The depth of knowledge we have is almost diametrically opposed. So to put it very simply, because we could have a whole symposium only on long QT syndrome, in long QT 1 and 2, the arrhythmias are adrenergically triggered, so often with exercise, fright, acoustic triggers, and this is because of lack of adaptation, reaction potential to a sudden change in heart rate. CPVT, also adrenergically triggered. And then on the left side of the slide, we have vagal triggers in long QT3 and Brugada syndrome. So these ventricular arrhythmias typically tend to occur in sleep or at rest, usually at night. And so we have this concept of the autonomic modulator, which will increase propensity to ventricular arrhythmia in long QT1 and 2, for example, if there's increased relative sympathetic tone. Now, this is an example of a patient who developed torsade whilst having an argument. They were under a lot of stress at home, and there are a lot of employment issues. And the management was beta blockade, implanting an ICD. But interestingly, in this case report, they also recommended a stress-free lifestyle. So I'm not sure if coming to live in California was the prescription for this patient, but I think it's sort of emblematic of the fact that all of us as clinicians recognize that stress, familial stress, employment issues, these all increase mortality. If you look at the social strata of individuals, the further east you move in London, certainly in my area now in Bart's Heart Centre, every tube stop, there's an increased incidence of sudden cardiac death from cardiac disease, and that's related to social status, employment issues, as well as diet. So if we think about the hierarchy of control related to stress, essentially the main centers related to increased stress are the insula and the dorsal cingulates. And then we understand better now the lower domains responsible for transmitting increased sympathetic drive through the brainstem. But we have no real treatments to modulate stress at a higher level. So perhaps this is a paper that I found just looking at yoga, and again in California, every time you walk around LA or San Diego, there's a yoga place on every corner, so obviously they've got the message over here. But interestingly, vagal tone is influenced quite significantly simply by eugiic breathing. So in yoga, you can breathe inspiration, expiration. If you match the timing of those equally, you will actually increase baroreceptor responsiveness, even in individuals who aren't trained in yoga for a long period of time. And this goes back, I think, to the talk yesterday, relating the fact that the respiratory centers very closely could drive the cardiac reflexes. And we really have no deep understanding of that interconnection. So if we go back to a simpler wiring diagram, which from Ardell's paper, we have the higher centers, the medulla, and then we have the soma around the heart and the cardiac ganglia, and finally you have control potentially at the myocyte level. Now, in Brugada syndrome, this is a condition of coved ST elevation associated with increased ventricular arrhythmia, usually in conditions of increased vagal tone. The focus, again, has been on substrate. So the people tend to use the tools that they have available. We're very good at mapping. We're very good at understanding local electrophysiology. And naturally, Brugada has now been recognized as a disorder of epicardial fibrosis. And by ablating the epicardium, you may reduce the propensity to arrhythmia. It's interesting that the ablation is occurring, the disease is localized to the right ventricular outflow tract, and ablation may be having more than just an effect on the substrate. This is a very elegant image just to highlight the importance of the vagal inputs, the chat expression in the ventricles. There's a densely innervated network of cholinergic expression in the myocardium. And indeed, if you look back at the literature in Brugada, there is a smattering of data to indicate that there is an abnormality of autonomic innervation in the right ventricular outflow tract and the inferior wall of the left ventricle. These are MIBG scans in patients with Brugada syndrome, and you can see there's reduced uptake of the inferior wall of the LV and also of the right ventricular outflow tract, suggesting there's an imbalance in autonomic tone in this condition, and therefore the imbalance here will be more prone to an increase in vagal tone. And indeed, this is data we're just putting together in submission now for a paper where we took a group of patients where we mapped the endocardium and the epicardium, and we looked at the endocardial-epicardial gradient. This is in control. There's virtually no gradient because of normal electrotonic coupling. When you give edrophonium in a normal patient at slow heart rates, the gradient is increased. In Brugada syndrome, there is a resting gradient, and that's exaggerated with edrophonium. So there's an increased propensity to transmural dispersion and repolarization, which is directly influenced by increased cholinergic drive. And indeed, if you take an SCN5A knockout mouse, which is a murine model of Brugada syndrome, SCN5A mutations being the most common mutation in Brugada syndrome, you actually see that the tissue, the myocytes, when in culture, are more resistant to isoprenaline. You don't get an increase in conduction velocity administering isoprenaline compared to control. So there's a resistance to adrenergic drive. So that would suggest an increased propensity for increased cholinergic tone, promoting action potential prolongation, promoting ventricular arrhythmia. So at the cellular level, I've been asked to talk specifically what are the neuromodulatory targets. And essentially at the cellular level, as you well know, we have beta-1 and muscarinic receptors, and these operate through G proteins on adenylate cyclase. So is there a possibility we can modulate GS or GI coupling in these conditions to reduce the propensity to arrhythmia? So there are over 300 non-odorant G protein coupled receptors, and there are 4 families which are linked to adenylate cyclase. So essentially, is it possible to use genetic techniques to modulate, for example, SA nodal activity by upregulating GS or upregulating GI to slow or accelerate the heart rate? This could be useful, for example, in Brugada, because you tend to get arrhythmias with bradycardia. So if you had a resting, maintained tachycardia throughout the day, this may reduce your propensity to transmural dispersion and repolarization. So one can do this with a conditional knockout strategy. This is data from Andy Tinker's lab, one of my colleagues in London, where if one overexpresses if one inhibits GS or GI using a conditional knockout model, one can see changes in heart rate in the mouse. So here, mice are usually active at night, so you would expect a tachycardia more at night as they're running on their wheel at night. And you can see here, if you inhibit GS, the stimulatory G protein, there's no increase in heart rate at night. And oppositely, if you actually inhibit GI2, you get a resting tachycardia. And indeed, in these mice, you actually see a general loss of low-frequency power with a loss of GS and a loss of high-frequency power with GI2 on heart rate monitoring. So this suggests that if one can target GI in the SA node, you may protect against ventricular arrhythmia in conditions where bradycardia is important, such as Brugada and long QT3. However, this is a targeted approach. You might think, well, this is great, but the problem is mainly in the ventricles. So perhaps if we inhibit GI, we might be able to reduce the probability of ventricular arrhythmia in these more bradycardic conditions. The problem with this, as soon as you start to knock out GI on a global level, you get quite marked changes in ventricular electrophysiology. First of all, there's a prolongation and corrected QT interval. Also, you have more inducible ventricular tachycardia in the murine model. And also, the VERP is shortened. So one actually creates a much more pro-arrhythmic condition with this global knockout. So if we're going to start using drugs to modulate GI or GS, we're going to have to be extremely specific because we can turn what was a relatively stable situation into a very unstable situation. So that's all very well when we look at the myocyte and G protein coupled receptors as a potential target. What are the centers at the higher level in the brainstem? So you've heard in quite a lot of detail now about the vagal centers and the DVMN and the rostral ventrolateral medulla oblongata, RVM, which can regulate vagal tone. And this is work that's been undertaken by Richard Ang, who's here attending here from UCL in Alex Gurin's lab, where it's possible to modulate DVMN activity by introducing allostatin using a viral transfection approach. One can upregulate allostatin, which then inhibits potassium channel activation and switches off the DVMN. So this is central neural control to inhibit vagal tone. One can see here that if one undertakes this experiment, it actually reduces the VERP in the myocardium. It also lengthens the corrected QT interval and also increases the propensity to induce ventricular tachycardia. So this intervention, which potentially could be beneficial if you want to increase the heart rate in patients with long QT3 or Brugada, again, could be potentially arrhythmogenic, even though it's an incredibly precise mechanism of control. The second approach will be to modulate the RVLMN, which also inhibits DVLMN, and you get very, very similar effects, an increased propensity to VT and a shortened VERP. So you're essentially upregulating sympathetic tone by switching off these vagal centers, and there are a lot of off-target effects on the myocardium. So I've mentioned already we could use potentially more sophisticated targeted G protein approaches in the myocardium or in the peripheral ganglia to modulate sympathetic or parasympathetic tone. But are there other approaches we can undertake that are non-pharmacological, either genetically or with devices or surgery? So we've briefly mentioned neuropeptides, and again, I think this is just an area which is completely wide open for neuromodulation treatment, both in inherited arrhythmia syndromes or the generally for ventricular arrhythmia. And again, there's remarkably slim literature on this. If one looks at somatostatin, this is in the 1980s, somatostatin has been shown to prolong atrial ERP and also cause AV nodal delay. So potentially, again, there's a whole host, there's probably a whole load of what one would actually call what bind and grind pharmacology one has to do to look at these specific neuropeptides, see if they potentially could have a therapeutic impact. The simplest approach and one of the most effective is to undertake a sympathectomy, and this has been shown to be very effective for long QT and CPVT in resistant patients. Unfortunately, the field of neuromodulation directly using electrical approaches is still really in its infancy, and I think one of the big problems here is that people have moved too quickly to a therapy without understanding the biology. So in the NECTAR-HF trial, a cuff was placed on the vagus nerve to stimulate vagal activity in patients with heart failure, a potential benefit, for example, patients with long QT, 1 or 2, where you want to increase the vagal to sympathetic balance. The problem with this study is that it was ineffective because there was no biomarker of actually measuring whether you had an efficacious response in the myocardium. One can also undertake tragus stimulation to stimulate branches of the vagus nerve, and this has been shown to actually reduce the propensity to induce atrial arrhythmias, atrial fibrillation, and the duration of AF. So there's clearly an opportunity to modulate cardiac electrophysiology with vagal stimulation, but at the moment the tools we're using are extremely primitive. One potential approach to modulate vagal activity is to use an optogenetic approach, and this is data from Alex Gurin's lab, where one can introduce an optogenetic probe into the DVMN, shine a light, and then modulate cardiac electrophysiology. And this is data that was produced from looking at a post-MI model to look at changes in ejection fraction in response to optogenetic stimulation. And there's ongoing work in the lab to evaluate this methodology to see how it changes cardiac electrophysiology. Interestingly, it's quite tricky, obviously, to start to introduce optogenes into the brainstem, but it's much, much easier to access the peripheral nerves. And a very simple experiment to do is to introduce optogene into the vagus directly and then see whether there is a response with light therapy. And this is an abstract from last year's Heart Rhythm, where that experiment was undertaken, optogenetic gene expression in the vagus nerve with channel rhodopsin. And you can see here you've got a resting tachycardia at the beginning, and then with shining a light, the tachycardia wanes. So indicating that one can actually modulate cardiac electrophysiology directly through the vagus with this technique. What's quite interesting also is that the effect is relatively small. You get a 20 to 30% reduction in heart rate, but when you give a cholinergic antagonist, you get an 80% reduction in heart rate. So the effect is there, but it's relatively small. The other issue is that could you actually inhibit sympathetic activity? And this is work from Professor Cheng's lab, where one can actually record sympathetic nerve activity in the skin. And you can see here in this case, this patient was developing ventricular tachycardia. Before the onset of ventricular tachycardia, there's an increase in sympathetic activity. And this really raises the question is whether one can actually, if one detects this early, and we know the threshold at which this level of activity is likely to be clinically significant or important, that one perhaps could hyperpolarize the sympathetic, the stellate ganglion, for example, to suppress the activity before it actually starts to occur, and therefore before it starts to influence the cardiac electrophysiology. The issue with all these approaches is that of adaptation and tolerance. This is C. elegans, a very primitive worm, as it were, that's used in a number of neurobiological experiments. And this is just the response to an odor stimulus in the C. elegans model. And one can see that continuously exposing this C. elegans to the stimulus results in an adaptation response. So any treatment we're going to undertake in the peripheral nervous system, in the autonomic nervous system, is going to have to be very carefully modulated to avoid this problem of tolerance and adaptation. And the final issue is, as a challenge really to the community undertaking this work, is the fact that at the moment, if we're using, for example, vagal stimulation to inhibit ventricular arrhythmia, that one has to sort of balance this against the potential efficacy of pharmacological approaches. So this is an experiment from Andre Ung's lab, where they undertake vagal nerve stimulation and look at the VF threshold. And as you use high-frequency vagus stimulation, you raise the VF threshold. Interestingly, if you use high-frequency sympathetic nerve stimulation, the vagus effect is much more reduced, and it's all drowned out by metoprolol. So if one's going to use vagal modulation, it's probably only going to have a very small clinical effect, and it's going to be more prudent, for example, to undertake inhibition of sympathetic activity as opposed to try and modulate vagal activity. So in conclusion, neuromodulation certainly represents a promising strategy to treat inherited arrhythmia syndromes, but the treatment has to be extremely targeted and titrated. And really, again, this brings us back to this whole issue of better understanding cardiac autonomics and these potential off-target effects of dispersion, of repolarization, and changes in refractoriness, which can in themselves be pro-arrhythmic, exactly the opposite of what we're trying to prevent. And we have a number of technologies that we can actually use to treat to employ these specific strategies, many of which we've discussed today. I think but the key, again, is to drill back down to mechanism and try and simplify any strategy that we actually use. Just like to highlight the fellows in my group working in London, and also my collaborators in Oxford and also at UCL. Thank you for your attention.
I think what we'll do is save the questions to the forum at the end of the session. Great. Sure. Go ahead. No. You go around the other side. Okay. Work here. The prior talk is a very natural segue into the next. I'd like to welcome my colleague, who will tell us about vagal nerve stimulation and the local myocardial effects.
Thank you, Olu. And thank you for the home audience, as well as all the people that traveled here. We really appreciate having you and learning so much today and yesterday about the autonomic nervous system. So I'm going to try to focus my talk primarily on vagal nerve stimulation for ventricular arrhythmias and its electrophysiological effects. I think that atrial fibrillation has been covered and will be covered further, and some of the modulation therapies that Dr. Lambiase talked about I'll allude to, and perhaps together we can all come up with a better way to do vagal nerve stimulation. So I'd like to thank the National Institute of Health and the American Heart Association for funding a lot of the studies that you'll see today. And I'm going to briefly just put up this picture. You've seen it multiple times now, to say that most of my talk will now focus on these afferents going from the heart to the brainstem through the nodos, and then these efferents coming from the brainstem down to the heart. So it's been, alluded to multiple times today that the efferent innervation to the cardiovascular system comes from the nucleus ambiguous, parasympathetic wise, and the dorsal motor nucleus, and that there are significant afferent fibers that receive direct information from the myocytes, both atria and ventricles, that travel through the vagal nerve via these pseudo-unipolar neurons in the nodos ganglion and up to the NTS. And the NTS does provide feedback on both nucleus ambiguous and potentially the dorsal motor nucleus of the vagus. The reason I bring up the afferent fibers, it's because it's been well established that over 80 to 85% of the fibers in the vagus are afferent. And so when you were talking about vagal nerve stimulation, you have to keep that in mind. These afferent fibers were, beautifully described in 1953 back by Dr. Pental, who did single afferent fiber recordings and actually recorded from these afferent fibers in the vagus and found that some of them were pulmonary stretch, some of them were type A right atrial, some of them were type B left atrial. So you would get all sorts of different types of afferent fibers going through the vagus, mechanoreceptors, chemoreceptor type fibers throughout. And some of this work was validated by none other than Dr. Drew Armour, sitting right out there, showing that if you recorded from the nodos ganglion, that inferior vagal ganglion, that you would be able to find neurons that responded to various stimuli, including voratrigine, nitroprusside, histamine, as well as mechanical stimuli. So all suggesting that there are all these different fibers. We don't know exactly neurons, what they're doing, how they're connected to each other, how they talk, if they talk to each other, and how they talk to each other. So we've kind of taken that single electrode technique, and as part of the SPARK initiative, we're trying to do multi-electrode recordings from the nodos ganglion in order to be able to better follow and classify neurons that are sitting in the inferior vagal ganglion. And one of the ways we can do that is we can take our raw nodos channels and now start to identify single neurons by their electrogram, by the morphology of their electrograms. And the nice thing about following single neurons by the morphology of electrograms is that you can now follow them over time and the responses to various interventions. So, for example, when you start getting nodos recordings, this is sort of a single electrode raw channel that you may see. But if you start to now classify your neurons by their electrogram morphology, what you'll see is that when you do right stellate ganglion stimulation, so you're activating the sympathetics, completely different area, some of the nodos neurons will actually suppress their activity. And this is at about 20 to 30 seconds where you actually see peak effects of right stellate ganglion stimulation. But there are actually others that increase their activity. And you would have maybe missed that by just looking at this raw recording where all you're seeing is a decrease potentially. So then you can take these same neurons, which are shown here, and look at their responses to different interventions. So when you do PVC inductions, when you're putting in PVCs at random intervals, you start seeing an increase in activity of both of these neurons in the nodos ganglion. And when you cause VF, what you'll start to see is a burst of firing both of these neurons, and then everything quiets down. So then you can actually do different interventions, including right vagal nerve stimulation, stellate stimulation, mechanical pressure and touch, responses to adenosine and voratridine, and look to see which of these neurons are able to transduce many of these chemical and mechanical stimuli, and as well as just autonomic interventions and how they could potentially be related to each other. In regards to efferent fibers to the ventricles, I think that we talked a little bit yesterday about, for many years we thought that there was no vagal efferent innervation, that there were no parasympathetic fibers to the ventricles. And so it wasn't really probably about 2 to 3 decades ago that we started to notice that there was actually acetylcholinesterase positive nerve fibers in addition to TH positive nerves in human hearts, and began to understand their distribution, with them being predominantly distributed at the base with sort of a gradient that went down to the apex, actually very similar to the sympathetic nerve fiber distribution that's been described. Now, we're all electrophysiologists, not all, but many of us, and we love to map, and we like to map with all sorts of different types of electrodes. And so we can have plaque electrodes or sock electrodes, as well as multipolar electrodes placed in human hearts. And we can look at what autonomic intervention does to electrophysiology of the ventricles using this method. So this is a porcine heart. We place a sock electrode on the heart. We're going to do bipolar vagal nerve stimulation. We are getting a polar map thanks to Dr. Lux and his crew in helping us with these studies. And what we can record from these multi-electrode socks or plaques are unipolar electrograms, and we can use these unipolar electrograms to measure something called ARI, or activation recovery interval, which has been shown by Dr. Lux and others to be a nice correlation with local action potential duration, so that when you have ARIs at multiple diastolic intervals, they actually correlate very nicely with local action potential duration using MAP catheters, for example. And so then when you go and you do your vagal nerve stimulation, what you find is that there's an increase in global ARI across all your electrodes, and that there's really no significant regional innervation by right versus left. That's very different than what Olu alluded to yesterday, which is that the right stellate and left stellate can have different activation innervation properties. The left stellate can cause greatest ARI shortening on the posterior aspect of the ventricle, whereas the right stellate can cause the greatest APD shortening or ARI shortening on the anterior. When you do right versus left, and this is your baseline polar map of what the ARI looks like, most regions will increase their ARIs in a similar fashion, with no significant differences between right and left vagal nerve innervation on the ventricles. So clearly the signals that are coming down through the right and the left vagus, which are preganglionic, are basically getting homogenized out, distributed out to all aspects of the ventricle, whether you're stimulating the right or the left vagus. So these were all normal studies, and the question is, well, increasing parasympathetic drive, is it beneficial for heart failure and ventricular arrhythmias? Now, going back many, many years, there's been studies that had shown that vagal nerve stimulation reduces ischemia-driven ventricular arrhythmias. So no real data in the setting of structural heart disease that's chronically remodeled, but in terms of if you could cause ischemia, and if you started VNS before causing ischemia, you saw less ventricular arrhythmias. Now, a lot of these studies were done, unfortunately, in a decentralized state, and I'll talk about why that's important. So they cut the vagus and they stimulate the distal end. And there was no sort of a target as to what type of stimulation you were going for, with a decrease in heart rates that were ranging from 0 to 100%. So from little bradycardia to significant bradycardia. The reason keeping in mind the afferents in an intact vagus is important is that, when this is a pig study where all we did simply in a normal heart was we stimulated the intact vagus, then we cut the vagus and we stimulated the vagus again, just below our transection. And we cut the right and the left and stimulated the same vagus again. So all we were trying to figure out is what is the effect of vagal nerve stimulation on those afferent fibers, and maybe we can just cut them out of the way and figure out how those efferent electrophysiological effects change. And one of the first things that you notice is threshold of stimulation. So if I need 2 milliamps to get a 10% bradycardia, now, after cutting the vagus and stimulating the distal end, I actually need much lower currents to get that similar bradycardia. And if I look at my activation recovery intervals and the percentage change in my APD prolongation, I actually get much greater APD prolongation after cutting the vagus than I did when the vagus was intact, all suggesting that activation of those afferent fibers, whether it's through activation of the sympathetic subsequently, so reflex activation, or through the other vagus, is fighting your VNS. It wants to take it back to where it was before, and so it's actually reducing the effects of your electrical stimulation. And this was a study in a similar way that was done by Dr. Ardell, but now he looked at different currents of stimulation. And what he showed is that in a canine model, when you stimulate the intact vagus, at lower currents, you actually get a tachycardia response. And it's not really till higher currents at a fixed amplitude of 20 hertz that you start seeing your bradycardia response. And this tachycardia response goes away when you cut the right vagus. So again, implying that there is activation of those afferent fibers, that they're not behaving in a classical way that we think about them. So, you would think that baroreceptor afferent activation would actually increase vagal outflow. But electrical stimulation is capturing fibers that are actually causing tachycardia at lower levels of stimulation. And so something to keep in mind with all of these studies is how the stimulation is being performed, the current, the frequency, and the duration of the amplitude, and how it is being titrated. What is the end response that it is being titrated to? So if you look at Nectar-HF, which performed stimulations at 20 hertz, this was a clinical trial of vagal nerve stimulation in heart failure. Because they were stimulating at 20 hertz, they weren't really able to get much higher intensities beyond this point due to side effects. And so if you look at now, do a dose response curve in a canine model, this basically falls right at the tachycardia threshold. So perhaps it's not a surprise that they didn't see a response. This was where these are the parameters that CardioFit used to stimulate, where we actually don't really see much of anything. You're at such low frequency that you don't see electrophysiological effects, and they didn't see any heart failure effects. So perhaps Anthem-HF, which is one of the few studies that has shown some positive results of VNS and heart failure, is the only one that seems to be stimulating at this neural fulcrum, which is an area where you're sort of sitting between this 5 to 10 hertz frequency and mid amplitudes in order to avoid side effects, and perhaps we'll be able to see benefits in both ventricular arrhythmias and heart failure. Now, as an electrophysiologist, I deal with recurrent ICD shocks a lot, and sending patients for VT ablations and then watching them recur again. And this is because, as many of us know, myocardial infarcts are complicated structures. An infarct has fibrosis, collagen, necrosis, and all sorts of remodeling that occurs at the myocardial level. And what we tend to target in most of our VT ablation studies are these live islands of myocardium, which now in a porcine infarct you can also see pretty well. So it's really different than a transmural infarct that you get, say, in a mice model or a rat model. And so the question is, if I take this type of an infarct and I do vagal nerve stimulation, do I do anything to ventricular arrhythmias, provided that I do it at that 10 hertz frequency and the lower thresholds where I am not banging the vagus and I'm not causing a tachycardia response. And so that's essentially what we tried to do in this chronic infarct model, where we created our porcine infarcts, we mapped them. The gray area represents what are considered dense scar. The rainbow color are the border zone regions on an electron-atomic map, and then the purple is the viable myocardium. This infarct is very similar to human infarcts, so you actually see similar types of bipolar voltage changes that we target in an ablation. So you get long fractionated electrograms within the scar, fractionated electrograms on lavas within the border zone. And one of the first things that we wanted to do, and we had no data on, is what happens to neurotransmitter levels at each of these regions. And we were able to do this with the help of Dr. Bill Woodward, who's sitting out there, and Beth Habecker. And so what we wanted to do is figure out what happens to these neurotransmitter changes. In a sham model, in a normal heart, there's actually very little difference in acetylcholine contact or norepinephrine contact in various regions of the LV, whether you look at the apex, the anterior wall, the lateral wall, and the same is true for norepinephrine. There's very little differences in acetylcholine content. I'm not talking about innervation when it comes to epi and endo, both in terms of the ventricle. So norepinephrine also has no difference between epi and endocardium. That was significant. But now when you look and get samples from what are scar, border zone, and viable regions based on your mapping data over here, what you find is that the acetylcholine levels pretty much in the infarcted myocardium are preserved, or perhaps even slightly greater than what you'd see in a normal heart. The scar does have a significant reduction in acetylcholine content. Perhaps that's not surprising, but even this difference from a normal heart to a scar region of an infarcted heart is just barely significant. This pattern is very different than what you'd see with norepinephrine. In norepinephrine, with norepinephrine content, the scar, border zone, and viable regions all have less norepinephrine than what you saw in a normal heart. So perhaps even what is affecting norepinephrine levels and acetylcholine levels with the parasympathetics for the sympathetics is different. You are getting different acetylcholine content, norepinephrine content, depending on which regions you look at. So there seems to be definitely stuff that suggests that in the ventricular myocardium, acetylcholine is at least preserved in the border zone and viable myocardium. And perhaps you can take advantage of that with vagal nerve stimulation. You're not running into a problem, perhaps, where the neurotransmitter contents are extremely low. So there's remodeling we know that occurs at the higher levels. This is now the cardiac ganglia. These are neural recordings that were done by Pradeep Rajendran, who's sitting out there, where he looked to see how the neurons in the cardiac ganglia of the heart remodeled with myocardial infarction, again in a porcine heart. And what he showed is that even responses, and I'm sorry this didn't show, this is normal, the blue is normal and the orange is MI, even responses to such simple things as IVC occlusion, which is preload reduction for any cardiologist, right, is very different in the infarcted neurons as compared to the normal neurons. If you specifically now focus on the parasympathetic neurons in this cardiac ganglia, and the way we classify parasympathetic neurons is by how they respond to right or left vagal nerve stimulation. Do they have a response when we stimulate the right or the left vagus? What you'll find is that the firing frequency of both right and left vagal nerve neurons in the cardiac ganglia is significantly increased as compared to the controls. They both will, for the most part, decrease their firing frequency with vagal nerve stimulation, but that this baseline abnormality in firing frequency suggests that perhaps the input from the parasympathetic nuclei sitting in the brainstem is significantly reduced so that they're overactive, basically. The other thing that we can do is we can try to classify the type of neurons that are sitting in the cardiac ganglia. And what you'll notice in both controls and MIs is that there isn't a huge distribution change in whether you have convergent neurons or efferent neurons, parasympathetic efferent neurons or parasympathetic convergent neurons. But what is different is the percentage of convergent neurons that are not just parasympathetic anymore, but are now receiving sympathetic input. So the red here is parasympathetic efferent only. The crossed red here is parasympathetic efferent plus sympathetic input. The light blue is what is traditionally parasympathetic convergent with no other inputs from the sympathetics. And now you have parasympathetic convergent plus sympathetic input. And you can see that many of these neurons, the 79%, are receiving now sympathetic inputs. So there's actually a change in the connectology of what were traditionally only parasympathetic convergent neurons. But if you then look at the relationship of all these neurons, and we're trying to do the same thing basically in the nodose ganglia, except the nodose ganglia luckily doesn't have any efferent neurons, they're all sensory. In the cardiac ganglia, what you can see is that these, whether it's LV mechanical touch or sympathetic ganglion stimulation or IVC occlusion, these neurons are related to each other and they do respond to the same type of stimuli. In a control heart, in an infarcted heart, it seems that for the most part that network is preserved. The underlying network is preserved even though there's still now additional changes that are coming from the sympathetics. So again, what that means is that the pathways are intact if you do VNS potentially in the right way. You can take advantage of the fact that you have acetylcholine levels in the heart. You can still take advantage of the fact that the cardiac ganglia exist and they have the initial pathways and communication lines with each other to be able to translate your neuromodulation therapy into actual benefit. I just wanted to take 2 moments and talk about the changes that we've seen in the nodose ganglion specifically. You know, we've now seen histochemical changes in the cardiac ganglia that occur in those heart
in the cardiac ganglia, and finally you have control potentially at the myocyte level. Now, in Brugada syndrome, this is a condition of coved ST elevation associated with increased ventricular arrhythmia, usually in conditions of increased vagal tone. The focus, again, has been on substrate. So people tend to use the tools that they have available. We're very good at mapping. We're very good at understanding local electrophysiology. And naturally, Brugada has now been recognized as a disorder of epicardial fibrosis, and by ablating
changes that occur in the stellate ganglion that's been reported, and we now actually have changes that occur in the nodose ganglion. So this is an infarct causes multi-level changes. It doesn't matter if you're on the heart, in your thorax, or outside the thorax. With all the neurons, that are autonomic or cardiac autonomic. And so here, we just did a simple study. You can see that the distribution in size of MI neurons in the nodose ganglion increases. And there's definitely changes in the types of neurotransmitters and neuropeptides that you see. So for example, tyrosine hydroxylase neurons, which actually exist in the nodose ganglion, their percentage goes up. The nNOS positive neurons, their percentage goes down. The CGRP neurons, their percentage increases. So there's the same histochemical remodeling that's been reported in many of the cardiac ganglia, now also observed in the inferior vagal or the nodose ganglion. So what happens if I take my infarcted heart and I do my nice level of vagal nerve stimulation? Well, one of the things that you'll see is that in control hearts, you get some mild prolongation of global ARI, but actually at the same level of frequency and the same thresholds, the global ARI changes that you see in an infarcted heart is greater. Perhaps this is taking advantage of that increased acetylcholine levels or availability that you see. And the greatest effects, and here's my infarcted area, sort of at the apex anterior wall of the LAD, seems to be in these border zone regions. It really just wipes out that area and homogenizes all that border zone heterogeneity. And that's shown here, where we looked at the percentage changes in activation recovery interval at baseline and with vagal nerve stimulation in different regions of the myocardium, so scar, border zone, and viable myocardium. And we saw that there's really nice changes in the border zone and viable myocardium that are actually greater than what you see in a control heart, in a normal heart. But what about VT-VF? And again, there's very little data on vagal nerve stimulation and VT-VF, even inducibility in infarcted hearts. So what we did was we took these same infarcted hearts, we induced VT-VF in them. Then we performed intermittent vagal nerve stimulation, and we saw a significant reduction in sustained VT-VF. And the significant reduction seemed to be driven primarily by stabilization of the border zone. So this is a dispersion in ARI graph, where you can see at baseline the border zones have the highest dispersion or heterogeneity action potential duration. Again, perhaps not surprising. And so with vagal nerve stimulation, this is the region where you see the most significant reduction in dispersional repolarization, perhaps helping stabilize that heart. And finally, I just wanted to show this data. This is a human heart where we performed vagal nerve stimulation through the internal jugular, and we're pursuing these studies actively as we speak. You can get your same electron-atomic map. You can put a duodec in regions of viable border zone and scar myocardium. You can do your VNS and start to see that you get ARI prolongation. This axis is supposed to be ARI on scar border zone and remote myocardium. You can already get a hint that perhaps the border zones are the regions that are most responsive also in human as well as infarcted porcine hearts. And so with that, I will stop and we'll continue.
Thank you, Marmar. Please note your questions for the discussion section. I'd like now to introduce our second last speaker today, Dr. Hari Tandri from Johns Hopkins University, who's going to talk about the role of sympathectomy in autonomic modulation.
You want to just use this? Hang on. Did you update it? No, right here. Let's do this one.
Thank you. I'd like to thank Shiv and Jeff for calling me here. I think the task that was given to me was to talk to you about sympathectomy. I'm a clinical electrophysiologist from Johns Hopkins, so my talk's going to be really bring it to the patient type of level. Really going to talk about stellate decentralization as a topic rather than sympathectomy. Sympathectomy is pretty broad. You could talk about renal denervation. You could talk about taking out the celiac plexus for hypertension, a lot of different ways in which you can look at sympathectomy. But this terminology of decentralization was introduced by UCLA to me to specifically deafferentize by taking out the stellate ganglia for treatment of ventricular arrhythmia. So I'm going to focus my topic on that. I call it the nervous heart. So I just wanted to introduce you to why I really got into this sympathectomy, and it really goes to this one patient. This is Sam Cockrell. He's a 17-year-old super athlete. Those are really fantastic pictures to doing all sorts of different athletic activities. He initially came to us about 3 to 4 years ago. He was an ultra athlete. He'd run 50 marathons since the age of 11. Can't even imagine doing that. It just makes me palpitate just thinking about that. In March of 2013, he was doing his laps. He came down, sat on the side of the pool, and was found to be slopped and was in VF. They defibrillated him, got him resuscitated by the EMS, got to the hospital. Couldn't find anything really abnormal in his evaluation. They thought that maybe his QT was slightly prolonged, gave him a diagnosis of long QT syndrome. They did throw in a secondary prevention ICD, and he was discharged home on no medication. They did start him on a small dose of a beta blocker. He couldn't tolerate it, but anyway, they just said you had long QT syndrome, and this was a resuscitated sudden death, and they sent him home. Well, he did well just for a brief while. 3 months later, he was running after his dog and had his first ICD shock. And at that time, had his ICD interrogated. Had several episodes of non-sustained ventricular tachycardia. And the family had done some research on the web and really found Johns Hopkins University. That contacted us for the inherited arrhythmia program to come and get evaluated. He came there, and after a series of evaluations, I don't want to go through the details of that, we thought that his diagnosis perfectly fit the diagnosis of right ventricular dysplasia, which is, I think most of you know that, but for people who don't know this particular entity, it's a rare form of an inherited cardiomyopathy, which usually occurs because of mutations in the cardiac desmosomes, the proteins which connect cell to cell together within the myocytes. And this has a very high incidence of catecholamine-induced ventricular arrhythmias, especially occurs in younger people, and athletic individuals are more prone to develop this. This is a high-dose isoproterenol infusion in this 16-year-old. As you can see, as we start to infuse the high-dose isoproterenol, he starts to develop polymorphic VT and then organizes into a monomorphic ventricular tachycardia. So he's very sensitive to catecholamines. Most of his arrhythmia episodes occurred in the setting of exertion, especially immediately post-exercise. And we did an endocardial voltage map. This is the first thing that we were trying to establish the diagnosis. This seems to be very specific for this particular entity of arrhythmogenic right ventricular dysplasia, having some scar on the basal subtricuspid region. As you can see, that's a voltage map of the right ventricle. That's the voltage map of the right ventricle. There's the outflow tract. That's the tricuspid annulus. You can see a very focal region of scar in the endocardium. He had a VT that was coming out of there. We ablated that successfully. We got all the VT that he had. He had some late potentials in that region. Kind of fit the diagnosis of right ventricular dysplasia. We discharged him home on a beta blocker. Again, he was not very good in taking his medication. He couldn't take it. He couldn't tolerate half the dose, and it was a lot of struggle. Again, what can you expect out of a 16-year-old to take his medication? But that's what it is. He was, again, very shortly after, he had, again, 2 ICD shocks. He was tolerating this whole thing very well. For a 16-year-old to get repeatedly shocked like that, he was very, even killed with all of that. In March of 2014, he had cardiac arrest after climbing 2 flights of stairs. He was walking with his friend. After walking about 1 flight of stairs, had about a flurry of shocks, had 4 shocks. He asked his friend to call 911 and basically collapsed on the stairs. And from that point had exhausted therapies, had more than 50 shocks from his defibrillator. He had CPR for 60 minutes. When the EMS arrived there, he was in fine VF and being paced. underdetected. The EMS thought that he was in a paced rhythm, and that's what they documented, but he was in VF. But then they realized that once he got back to the ambulance and started doing CPR again, I got a call shortly after his friend called his mom, and I picked up the phone. I called Sam. He didn't pick up the phone. So we weren't sure which hospital they were taking him to. It was a pretty interesting 2 hours from that point. Anyway, he ended up in an ER in middle of Mobile, Alabama, and had the interventionalist was put up percutaneous hemodynamic support because he was in a pulseless electrical activity. We insisted that he be put on a hypothermia protocol. I was basically calling the hospital every 2 hours trying to find out, did he move his leg, did he blink, did he breathe? It was really a traumatic 1.5 day. Anyway, this was what his rhythm was. You would have PVCs, go back into VF, and literally break and go back into VF again. And this is his device log. As you can see, he had repeated episodes of VF and getting shocked over and over again. Anyway, he did make it out of that. The next, about 24 hours later, he spontaneously woke up, and he was recognizing people. He did really great. And it was a time to celebrate, but what do you do next? Now, this guy, he had a defibrillator, but still had a full-blown cardiac arrest. So he was flown back to Hopkins University. We did endo and epicardial mapping. I come back to this because this is the only thing we know how to do. So that's what we've been taught how to do, right? Keep doing the same thing. So we did a mapping, and we induced 2 morphologies of VT. And again, I did an extensive substrate ablation. I was very careful not to put him back into VF because the whole lab was on red alert. And they weren't sure, if you put him into VF, are you going to bring him back? Are you able to do that? Because he keeps going into it. We put him into VT once, and it took me like 4 or 5 shocks in the lab to get him out of it. And everybody was like standing back saying, are we going to do this again? So 3 days later, I tried to induce him again with a lot of guts and couldn't induce VT at the time. We put him on the treadmill. He didn't walk all that much because he was just recovering from his cardiac arrest and all sorts. It was pretty traumatic. And all this while, there was this very involved family and asking all these questions. And what is his prognosis? Is he going to have this again? Should we let him go back to college? Should he get a transplant? And all sorts of stuff. Again, he went to a concert. A month later, he had another shock at a concert. Again, had lots of non-sustained VT. I started him on flecainide. There were a lot of considerations of cardiac transplant, other options, repeat ablations, and I was completely out of my wits. And I called Shiv, I called all the people in the field. I called Shiv. Shiv suggested, we should probably consider sympathectomy. I called UPenn, and they said, let's do a good real ablation. What? So anyway. I had read about Shiv's papers at that point, but I was a non-believer. I have to tell you that. And I looked at it like, what has this got to do with this anyway? So I thought this was all disconnected anyway. So I said, fine, weren't really sure what to do. So I chose the ablation route. So we took him to Penn. It was an interesting experience. Like this kid was 17. He couldn't make his decision. He couldn't sign on the paper. So it was really a big conflict. His parents were making the decision. He wanted to make the decisions. A lot of things going on. So we took him to Penn. As we were wheeling him into the OR, he goes into this VT. He's all anxious. You could touch his hand. It's cold. It's freezing. And as soon as he goes into the OR, he goes into the VT. And then they say, oh, boy, his pressure's dropped. Let's shock him or whatever. They gave him propofol. The whole thing terminates. Go back into sinus rhythm. They didn't even have to shock him. That's what they did. Again, they did a long EP study. We started at 9:30 at 10 o'clock in the morning. At 8 p.m., he had 5 different morphologies of VT still. And we were scratching our head what to do. And at that point, had a brilliant idea. Let's open the chest up and cryoablate the right ventricle. I said, hold on, let's back off here. So we went back to the family, and anyway, somehow one thing led to the other. They decided that this is the last resort. Let's try this anyway. So following morning, this is what they did. So got the surgeon in, opened up, cryoablated top part of the right ventricle, and basically at the end of it, they were very happy with the result. They closed him up. He did okay, just for a while. and then he had 6 shocks while he was trying to catch a flight. He was getting late for flights, running again. What worried me about this was that the first shock didn't terminate the VT, the second one didn't, the third one did, and then immediately it came back again, another 2 more shocks, and it was really pretty dramatic looking at those tracings. And so what is the next step? I've tried everything in our cookbook. Whatever we've learned, I've tried all of that stuff. I said, why not? What have we got to lose? Let's send him to UCLA. So anyway, what do you do in these things? What's your next target? And that's when we kind of explored this neuraxial modulation and what is the role of the brain in all of this? And it's very clear that if you have an arrhythmia, you get anxious. If you have anxious, you also get an arrhythmia. Basically, it seems that they're all very intricately connected. It's a closed loop. At this point, I just want to digress and go on the historic aspects of sympathectomy itself, very focused on arrhythmias. If you look at it, 1961 was the first report I found of doing bilateral sympathectomy for arrhythmia. And it's not much of a detail on exactly what they were targeting. This was a patient with ventricular arrhythmias. And if you look at this, all they were focused on was prolonging conduction, meaning an antiarrhythmic effect. That's what they were shooting for. And somehow doing the sympathectomy led to some antiarrhythmic effect in the heart. They're talking about the conduction changes that actually happen when you do left and when you do right sympathectomy in a patient. Unilateral sympathectomy for long QT kind of started in about 1971, became very compelling. If you look at this, where the patient with resuscitated cardiac arrest after long QT, immediate QT shortening that happens after left stellectomy. There was a flurry of publications, mostly by Peter Schwartz's group, looking at increase in VF thresholds after left-sided sympathectomy. There's a lot of controversy on what happens when you do left, what happens when you do right, should you do left or should you do right? There's a lot of controversy in the literature. I don't want to go into all of these. But it was very clear that the left-sided sympathetic chain was very important to arrhythmogenesis in the heart. VATS sympathectomy didn't catch up until 2003. 2003 found that looks like some early reports of successful VATS sympathectomy done for long QT syndrome. And the field has been dominated by UCLA since that time. And you can see that a lot of publications coming from UCLA on VATS sympathectomy and the clinical results after VATS sympathectomy. Just to go over what do they do in sympathectomy, basically, it's the lower half of the stellate ganglia. The ANSA goes all the way around the subclavian artery, and the C8 and the ANSA goes down, and the lower half of the stellate ganglia is what's being removed. Initially, it involved removing the ANSA, the T1, T2, T3, and T4, but now it seems that it's only up to T2 that's important, and maybe lower may not be involved, although it's work in progress on exactly figuring out what is important. It is clear that this is not entire sympathectomy because the superior cervical ganglia and middle cervical ganglia are very important in at least efferent connections to the heart. So what is happening by cutting it at this level is the afferents from the heart are effectively debulked. So there's decentralization of the heart, but not complete sympathectomy. So there's not a complete sympathectomy procedure, but only the afferents are involved. What happens if you cut a little higher up? You probably knock the nerve that goes to the lid, so you may have Horner syndrome. That seems to be the biggest downside of cutting higher up. I don't have any reports where middle cervical or anything have been taken out because clearly higher centers that are involved are very important. And so most of the surgeries are limited to just cutting the lower half of the stellate ganglia. And again, as I mentioned, there's a lot of reports from Olu and Marmar and Schiff's group on the effects of sympathectomy. It's complete, meaning it's not partial, it's not stimulation, it's not thresholds. It is when you take it out, it's out. It's in your petri dish. It's in my hand. It's gone. So this is a all or none kind of thing. Although even in this particular situation, I do realize that the surgeon goes and digs around and takes something out and he calls it the stellate. And you got to trust him, right? And so I do go there and I watch these surgeries, and this isn't easy. There's so much of variability in how it looks when you look in there. Sometimes it's all fat. You dig through the fat and you find nothing. Then you scrape and you end up on the bone. It's like, where'd you lose it? Oh, it's gone. So it is a tricky business. You need to know that. And I said, oh, wow, great, I can figure this out. Let's put a probe in there and stimulate it, and now we know what exactly we're doing. No, that's not easy either. We don't have good methods of intraoperative stimulation. The VATS scopes are designed for something else. We're using it for stellatectomy. We need a lot of tool development for better performing what we know how to perform even today. So anyway, but this is the best we have, so let's go with this. So it's clear that when you do stellatectomy, there's significant reduction in ICD shocks. And this is a paper by, again, Olu, published in 2012, clearly showing in a small number of patients where there's been significant reduction in ICD shocks. Again, these patients are complete extreme of the picture. These are not the patients who come in with PVCs that we ablate day in and day out. It's not AFib. This is real deal. These patients have been multiple times ablated, put on several antiarrhythmics, probably not able to think because of so much sodium channel blockade. And they'll say yes to everything. So it's a very tough cohort of patients to deal with. And in these patients, to achieve that is something really significant. And if you look at unilateral versus left-sided only, it's clear that doing bilateral is beneficial. I don't know exactly what the thought behind that is. It's possible that maybe this compensation that happens when you cut one, the brain may adapt to control the other side, or maybe there's a beneficial effect of doing it on both sides. But it's clear that bilateral works better than just left-sided alone. Again, CPVT, it's very clear. It looks like if you look in the guidelines, it's for long QT and CPVT, it's a standard of care. After you fail drug therapy, you just go and knock it out. If for polymorphic ventricular tachycardia, it seems that specifically it's for catecholaminergic polymorphic ventricular tachycardia. As you said, it's calcium-sensitive mechanisms, and seems like a stellar ganglia ectomy clearly reduces arrhythmic episodes. But what we are focused on is to cubby-holing people into saying, you have CPVT, you have ischemic cardiomyopathy, you have non-ischemic, but in reality, everybody shares phenotypes of all of these things. There's so much overlap. I can induce VT in ischemic cardiomyopathy with giving tons of isoprol. It's not that you can separate these people out into groups. Again, this is another data. It's a little group of patients from Di Ferrari et al. Showing that clearly there's before to after this reduction in major cardiac events, and mostly this is about syncope and also ICD therapies. It's being done in Chagas disease. This is a report in Chagas disease from Brazil. You can you can see that before and after, clearly there's a significant reduction in ICD shocks in patients after sympathectomy in Chagas disease. And in Chagas disease, again, it's an extreme form of structural cardiomyopathy. If you see one of these MRIs from the Chagas disease, it's all over the place. It's almost like somebody squeezed the heart out and stretched it out. It's like it's so much of structural heart disease in there, and it seems to work in Chagas disease. And this recent report showing left cardiac sympathetic denervation in heart failure. So if you step back and look at it, a hypersympathetic state exists in heart failure. It exists in a lot of different cardiac conditions and uniformly associated with poor prognosis. So it kind of stretches your limit of thinking about where could this be important. And it seems that it should work everywhere a beta blocker does. And everywhere a beta blocker has some role in improving prognosis, cutting the sympathetic tone may have a role. I just want to thank Marmar for giving me a bunch of slides on one of the largest studies ever published on cardiac sympathetic denervation. We don't really have randomized control trials. I'll come down to why that is so and down the road. I'll just explain to you a little bit about that. This is the largest study published today. It's about 121 patients. A lot of different cardiomyopathies mixed together. Ischemic, non-ischemic, sarcoid, ARVC, you name it. It's a mixed group of patients, suggesting that structure is not the basis. It's basically, they all share the common phenotype of having recurrent ventricular arrhythmias despite being on lots of antiarrhythmic medication. Following sympathectomy, there's a significant reduction. Again, this is good. If you look at AFib, persistent AFib, right? We celebrate. Wow, we've gotten a great success. And this is patients with ventricular tachycardia, refractory to drug therapy, refractory to ablation. We're getting a significant reduction in ICD and VTVF recurrence. If you look at the composite endpoint of death and heart transplantation, including VT and VF, is still do well, but I think there's definitely room to improve right there. Again, in concurrence with the prior studies, bilateral seems to work better than unilateral sympathetic denervation. It's substrate independent. Non-ischemic is a mixed bag of sarcoids, ARVCs, and really non-ischemic idiopathic cardiomyopathies. Ischemic cardiomyopathy, it really doesn't seem to matter what it is. So it kind of bears to question on the efforts to specifically look at mechanisms and how to treat specific mechanisms. And it seems like sympathectomy works to reduce your arrhythmia recurrence or increases your threshold for arrhythmias, no matter what your underlying structural heart disease is. So I'm not saying that this is the sole therapy. It's an adjunct. It is something that you have a lot of different therapies to offer for these patients. You have antiarrhythmics, you have ablation, yoga. Why not sympathectomy as an extra thing in your armamentarium when you're dealing with these difficult patients? Who doesn't do very well with sympathectomy? Patients who have no heart. Well, or class 4 heart failure. So if your heart's really failing, I think maybe sympathectomy may not be a great thing for you. So, but I think the patients who have a class 1 heart failure really do well. Patients who have a structurally normal heart, but their main problem is arrhythmia, they seem to do very well. Again, this slide again reiterates what I just told you. I think patients with a very long VT cycle lengths, meaning patients with really slow refractory VT who have a lot of scar tissue, and also patients who are in class 4 heart failure don't seem to do well with sympathectomy. And the same thing with death composite endpoint. So coming back to Sam, what happened to Sam? So I just want to come back to that. So we did a sympathectomy in Sam, and that was the last of his ventricular arrhythmias. This is post-sympathectomy, absolutely no VT, has had no arrhythmias since. 3 years have gone by. 6 months we celebrated. At 6-month time point, we all just like, this is it. It's like, and Shiv was saying, oh, that's too soon. Let's just wait a little bit. So 3 years have gone by. He's gone through college. He's now, he's done with all of that. And he still plays tennis. He's not on any medication. He's doing really good. Again, it's a very extreme case of saying how sympathectomy really made a big difference, because we did throw everything in the cookbook at him. And it was very obvious right from the beginning that his arrhythmias were sympathetically driven. Every time he presented, there was a component of a sympathetic overdrive in his case. And this was a perfect case where we should, explore that. And there he is. That's Sam. And he started this thing called Heart for Athletes. His mom runs it right now. He's a very good proponent of that. He still exercises. He's won so many honors even after that. He's doing really good. Well, that started a program at Hopkins. We started a sympathectomy program at Hopkins based on that. We backed off and said, let's take a look at this. Let's take a look at the beginning. How many of our patients are sympathetically driven? And how do we tease out who's going to benefit from sympathectomy and who not? So we started looking for patients who'd failed multiple ablations and who were coming back for the same thing over and over again. And we had 30 subjects who prospectively offered sympathectomy to all of these patients. They came in for an ablation. We also offered them sympathectomy at the same time. 12 patients dropped out. And 4 had prior chest surgery. Not a contraindication for sympathectomy per se, but when we are starting out a program for sympathectomy, we don't want to be taking patients with abnormal, chest wall previously surgerized and whatnot. So we actually didn't want to take patients with prior chest surgery. 1 had chronic lymphatic leukemia and anemia, 2 were on anticoagulation. 5 patients read about the procedure, they looked at all the videos, and they said, let's think about this. So they dropped off. And 2 patients, we failed the procedure. 1, the patient had undiagnosed chest wall adhesions. When we went there, we couldn't separate the pleura out, and it was so much bleeding and backed off. Unfortunately, that patient 2 days later turned her defibrillator off, and she decided to die because she didn't want to take the shocks anymore, and she died a week later. The other patient, where we actually went there, looked at it, there's so much fat, and we wanted to show what was need to be dissected. After about 2 hours of searching, we gave up. And I think 1 had, and that patient failed single lung ventilation, also had adhesions. 16 had sympathectomy, and 14 control subjects without sympathectomy. You can look at it, the results are staggering. 14 out of 16 are alive during follow-up, and actually 15 are alive. 1 actually went heart transplantation. I put them in the non-survival as well, just because that's they drop off the curve. 62% are free from recurrent ICD shocks. If you look at this group, only 8 or 14 are alive during follow-up. And almost all of them had ICD shocks, except for 2 patients. So these are again, the follow-up is not really long. It's less than 9 to 10 months of follow-up in the whole cohort. But you can see that there's so much of burden of arrhythmia, you can get your results pretty quickly. I just want to go over a couple of cases. This is a patient who's 50-year-old, non-ischemic cardiomyopathy. She had 2 epicardial ablations. It's interesting. All the patients from Baltimore go to Penn to get ablation, and they come back when they fail Penn. Maybe it happens the other way around at Penn. So she was on amiodarone and mexilitine. She had 50% PVC burden, and she was referred for transplant evaluation at Hopkins, not for ablation. She was referred for transplant evaluation. So this was her ECG. You can look at this, and some of them are sinus beats. You got to trust me on that. That was the day after sympathectomy. She's not on anything right now. She's on a beta blocker, carvedilol, and some heart failure medication. Her ventricular function did not improve dramatically. It's almost like now 1 year after doing this ablation. It hasn't improved dramatically, but she doesn't have heart failure anymore. She's off the transplant list. She doesn't have heart failure. She feels fine, and she has no arrhythmia. This is another patient, sarcoidosis, EF of 30%. She had recurrent VT. She failed flecainide, amio, and disopyramide. She was very interesting. She would be very good when we intubate her. When we extubate her, she'll go back into VT. So one of the options was that to keep her intubated all the time. But that didn't really fly very well. So every time she would walk around, she would get into VT. So this was her ECG. She would basically have this type of arrhythmia and then sustain in a long run of VT, and then it'll break and then start back again. She was profoundly lightheaded, and this was all, and she would go back into CCU on lidocaine, and then shortly later get intubated because the pressures are very low and all sorts. So this was a big struggle, and she had sympathectomy, and that's how it cleaned up. And again, these patients had something to suggest that they were all very sympathetically driven. That's another example of patient. This is at nighttime. This is after post-sympathectomy. This is the PVC burden. So I just want to close by saying, when it's effective, why is it rarely being done? And that's because you need a lot of these things. You need a cardiac surgeon, you need a favorable anatomy, you need to tolerate single lung ventilation. But I think there are also other issues, there are complications, pneumothorax, Horner syndrome, hypotension, lack of sweating of face and hands. And this is an example of a patient with unilateral left-sided sympathectomy done, unilateral sweating, and a slightly Horner syndrome right here. And there are minimally invasive techniques that are coming up through the back and going and ablating the sympathetic chain out there. Now, my most important question is, where do we go from here? This is one of these techniques which seems to work. It seems to work, and there are data suggesting that it can actually go to a human realm. And this is where I think UCLA has taken the lead, and we're very glad to be participating in this Prevent VT trial. Hopefully this will be up and running pretty soon. It'll be the first randomized trial asking this question on what's the benefit of doing cardiac sympathectomy in these patients. I think it's a very important thing. I think the reason to do this in randomized fashion would be to have more people embrace this approach even earlier in patients, and also to have more people look at this technique closely and industry to come in and make this technique more easy to do and develop toolkits to make this happen. So I think everything hinges on participation of academia in conducting this study and coming up with the results of the study. Thank you very much.
Thank you for a very fantastic talk, Harry. And we've saved the best for last. We're delighted to have Dr. Peng-Sheng Chen talk to us about neuromodulation and atrial arrhythmias.
Thank you, Shiv. I want to thank Shiv and all the organizers for inviting me to the talk. But on the other hand, also the last talk, and between you and a nice lunch. I do have a conflict of interest, as shown here. And before I start, I want to thank all my long-term collaborators on these projects. And we have been receiving donations from multiple companies to do this study. So in our laboratory, for the past about 10 years, we've been working on recording sympathetic nerve activity directly from ambulatory animals. So the initial study was simply implanting a DSI radio transmitter with electrodes connected to the left stellate ganglion, allow the animal to recover and intermittently pace atrium fast. And we paced for 6 days and allowed the atrium to not pace for 1 day and observe the spontaneous atrial fibrillation. We did show the simultaneous vagal and the stellate ganglion discharge seems to be preceding the paroxysmal atrial fibrillation episodes. We then did the intrinsic cardiac nerve recording, where we put bipolar electrodes directly on the left superior pulmonary vein and the ligament Marshall, and again allow the animal to recover and pace the heart 6 days and rest for 1 day until persistent AF is induced. We did find in 100% of the case that the intrinsic cardiac nerve activity was initiating the atrial tachycardia and fibrillation episodes. And in this particular episode, the intrinsic nerve activity preceded that of the stellate ganglion nerve activity, and the vagal nerve activity starts here. And in some other episodes, they all occur simultaneously. So from these observations, we conclude that at least in this ambulatory dog model, the nerve activity is important in the initiation of atrial tachyarrhythmias. The problem with this is that it's very hard to record either vagal nerve activity or stellate ganglion nerve activity from the humans. So it is up to us to translate these canine findings to humans. So we designed a method to record skin sympathetic nerve activity. And we have published about 3 articles comparing the skin sympathetic nerve activity with that directly recorded from the stellate ganglion. And there is roughly about a 0.7 R value. So it's not perfect, but it's probably good enough as a measure of the sympathetic nerve activity. The recording in humans is using ordinary electrocardiogram ECG electrode patches with a reference electrodes placed somewhere else. So this would be the lead 1 configuration. And in many patients, we also placed it on the right arm or left arm with the reference in the middle. And we convinced the manufacturer to increase the bandwidth of the recorder, of their myography recorder, to be able to record these nerve activity. So the basic principle of recording electrical signals from the skin is as follows. So this is a artificially generated signal going from 0 to 1,000 hertz. You can see that this signal initially has very low frequency going to much higher frequency. If you pass them with a 500 hertz high-pass filter, you eliminate the lower frequencies and you remain, the high frequency remains. Electrocardiogram generally has a frequency between 0.5 and 150 hertz. Actually, most of the frequency is on low end with a relatively low at 100 and 150 hertz. Muscle activity mostly still below 100 hertz, but there has been reports that I can find to see that the muscle spindle can go up to 400 hertz. There has not been any reports saying any muscle can activate at more than 500 hertz. And nerve activity is throughout the spectrum, actually goes beyond 1,000 hertz. But therefore, for specificity, the microneurography study typically high pass is 700 hertz, and the standard will be 700 high pass or 2,000 hertz low pass. In other words, band pass between 700 and the 2,000. That will be the standard microneurography study. So in the humans, you can see that there's intermittent bursts of nerve activity. Nerve activity actually is present all the time. It's all the time, with occasional bursts of this nerve activity that are usually associated with shortening of the RR interval. And as I will show in the preliminary study, it shows the development of arrhythmias. And a standard method of recording microneurography is to have patients do Valsalva maneuver. So this is during Valsalva maneuver, the heart rate increases, the average nerve activity also increases. So this nerve activity over here was, as I said, is present all the time. Now is increased because of the Valsalva. And when the patient ends the Valsalva, the nerve activity reduces, and there is a phase 3 and phase 4 response of the heart rate. So, and also the heart rate has slowed down. So this is sort of another consideration of the testing of the nerve activity. We have also asked the patient to put their hand, one hand in the cold water. This is normal volunteers. About 10 patients, and we can see the chest lead showed massively increased nerve activity on the chest and on the other arm. So that is the data that I don't have time to show. But what I really want to show is recall that at the time when microneurography was developed, people were very concerned whether or not these are simply noise. So finally, the investigators were able to convince the scientific community that these are actually nerve activity by injecting anesthetic blocking agents to block the nerve activity. So here is the patient on the table. Data was obtained from Dr. Yongmei Chow, Mayo Clinic. And when the needle goes into the patient, it has a massive sympathetic discharge. It is interesting to know that these are actually recorded from the right arm, but with left stellate ganglion injection of the lidocaine, there was an immediate transient slowdown, reduction of the nerve activity, followed by recurrence pretty quickly. It was then went to the right arm, and the nerve activity goes up and down until the right stellate ganglion was injected. Then the right arm sympathetic nerve activity was inhibited. We have 3 patients. The time of injection was marked by pushing the marker on the screen, on the recorder device. So it's a pretty precise timing in this. We are trying to do more studies on this to document the relationship. Finally, obviously, there's a need to compare that with a standard microneurography study. We call this method new ECG, and one of the first things we do is trying to compare the nerve activity on the skin versus atrial tachycardia and fibrillation in humans. So these, we did a preliminary study, skin sympathetic nerve activity in electrocardiogram, were recorded from 11 patients that was admitted to the hospital, including 4 males and 7 females with average 66 years of age with various kinds of diagnoses. These are the people, inpatients So they have pretty significant diseases. Among them, 3 patients had AT. And each patient has 11 episodes in average. And 8 patients has paroxysmal atrial fibrillation, each with 24 episodes per patient. These patients are not easy to collect, I have to say, because patients with paroxysmal AT and AF staying in the bed is not all that often. This is what we observed. This particular patient was quite interesting. You can see the nerve activity, skin sympathetic nerve. This is raw recording. And this is a 20 microvolt plus minus. The baseline sympathetic nerve activity of a normal healthy volunteer in average is about 1 microvolt. This is an integrated skin nerve activity, which we try to correlate that with microneurography. Therefore, it's 100 millisecond integration of this nerve activity. You can see this nerve activity has increased prior to the onset of atrial tachycardia, abrupt onset and fast heartbeat. And the most interesting thing about this particular patient who has 25 episodes of AT, before the termination of atrial tachycardia, there is a bump of heart rate. And that was correlating with a little bump of the sympathetic nerve activity. That happens repeatedly in this particular patient. This is onset of atrial fibrillation, a typical example that there is increased sympathetic nerve activity. Actually, the baseline nerve activity is pretty high. There was an increased sympathetic nerve activity and leading to the onset of atrial fibrillation. And at termination of atrial fibrillation, there tends to be also a nerve activity burst. So here's a burst nerve activity corresponding to the atrial fibrillation termination. We have tried to determine whether or not these are abnormal. So the black dots are the relationship between the average skin sympathetic nerve activity, microvolts, versus the heart rate. As you can see, the patients, hospitalized the patients, their skin sympathetic nerve rate tends to be high. There's always a positive association. But in this particular patient, the red dot, which is before the onset of atrial tachycardia, is higher than the entire range of recorded sinus rhythm atrial this nerve activity, and so is the final 10 seconds of AT. And so these 2 patients seems to indicate that the atrial tachycardia in these 2 patients are related to sympathetic nerve activity. However, in this particular patient, there is very large overlap between the 2. Atrial fibrillation is the same. Some patients, the atrial fibrillation seems to be at high range compared to the sinus rhythm. In other patients, there are significant overlaps. Statistically, the before onset, final 10 seconds, 10 seconds after termination, all have this nerve activity significantly higher than that of the sinus rhythm. However, there are significant overlaps. From this, if this can be generalized, which I doubt, there got to be different group of patients. The neuromodulation in treating atrial fibrillation would only be expected to be partially successful and not entirely successful. I know I have only 2 minutes left. We talk about the targets in neuromodulation. In canines, we have done cryoablation of the stellate ganglion, and that shows we prevent paroxysmal atrial tachycardia, atrial fibrillation, but we only delays the onset, but does not prevent sustained AF. In this particular study in heart rhythm, just published in 2016, the author said that the AF inducibility before and after stellate ganglion block in 36 patients, where he randomized 2 to 1 to 2 different groups, they found the stellate ganglion block suppresses the AF inducibility, and also left and right stellate ganglion block seems to have the same effect. So this is results that are consistent with our studies in canine models on paroxysmal atrial fibrillation. There are several clinical studies about denervation in treating atrial fibrillation. This I'm mentioning this one because it's a prospective randomized clinical trial in which 242 patients with paroxysmal atrial fibrillation, they specifically excluded the patient with persistent AF or AF has failed previous ablation. They did PVI, pulmonary vasodilation, ablation of left atrial GP only without anything, and the PVI plus left atrial GP ablation, and they follow up for 2 years and pretty extensively, ablating the GPs here. And what is interesting is that they found not only pulmonary vein isolation plus GP is better than pulmonary vein isolation alone, but they also noted that GP ablation alone had 50% success rate. Again, this is paroxysmal atrial fibrillation only. There is a recent study which is very well quoted and people pay a lot of attention to, is GP ablation in advanced atrial fibrillation. These are patients with failed ablation or persistent atrial fib, by and large, and they randomized into patient with GP ablation plus ligament Marshall ablation plus pulmonary vein isolation or pulmonary vein isolation only, and follow up for just 1 year. For one thing is that they have amazingly high success rate, 82%. The two curves does separate, but statistically they are not significant. If they break it down to paroxysmal group and the persistent group, paroxysmal group curve does separate at 1 year, but persistent separate much less. The authors suggested that the GP ablation doesn't work, doesn't help. And I have a little problem with that. The reason is that these are the study that they terminated 1 year. The arrow points to 1 year. In Catrice's study, which I just presented, the real break occurred at 2 year mark, not at 1 year. This is another study on persistent atrial fibrillation. At 1 year mark is 0.29 in terms of p-value. The significance only occur at 3 years. And finally, if you could recall, Dr. Moss has done this classical study, the MEDI2 trial. At 1 year, there's barely any difference between people on defibrillator and on conventional therapy, and only after 2 or 3 years did the effects occur. So one possibility is that they did not follow patient long enough. The other possibility is that the recent study has 59% persistent AF, quarter had previous catheter ablation failed, and only 11% had normal LA and no persistent AF. In contrast, Catrice's study has paroxysmal AF, LA diameter less than 50, and no prior ablation. So the results of this study actually is consistent with the results of K9 study. These are the people with paroxysmal atrial fibrillation only and the normal LA diameter, no prior ablation. These patients seems to be partially responsive to GP ablation, while the previous ones, while the persistent AF group, which was persistent AF was not prevented by extensive neuromodulation, and therefore the study was less positive. I suspect that going forward, the neuromodulation might be a procedure that might be somewhat helpful in paroxysmal atrial fibrillation, as supported by this randomized trial as well as others. But for patients with previous ablation, persistent AF, it may not be that helpful, or it will take much longer period of time before the benefit shows up. Thank you very much.
Thank you so much, Dr. Chen, and thank you for staying on time. To quote someone I know, Washington, D.C., we are hugely behind schedule, so I'd like to spend, maybe take 5 minutes for questions. Okay, 10 minutes, I'm being told, for questions. We actually have to be at the Plateia by 1 p.m., so if there are any dying questions for any of the speakers, and then after that we'll have Shiv and Jeff come up and give some remarks. Yeah, sure. Maybe we'll have the speakers come up. Speakers? Yeah, sure. Speakers. And oh yes, let's pass that out. Question from.
Thank you.
Yeah, Jim.
So, regarding sympathectomy and its role in preventing arrhythmias, you did show that it doesn't seem to be as effective in patients who have a reduced ejection fraction. But what I'm curious about is when you look at the data in patients with heart failure, and you look at heart failure progression, one of the worst prognostic signs is reduced sympathetic innervation as measured on an MIBG or a PET study. And in fact, those patients have the worst prognosis. And in fact, all of the things we know protect against heart failure protection, like beta blockers, like ACE inhibitors, like biventricular pacing, actually improve sympathetic innervation of the ventricle, and it seems to have a protective effect. So, do you think this is specifically related to the arrhythmia issue, or do you think it's, how do you reconcile those observations?
Do you want to take that, or do you want me to take that?
Please go ahead.
Okay, so I'm going to start off by just clarifying one thing, which is that what we saw is that patients with New York Heart Association class 4 don't do well. All of those patients had reduced EF that were on the order of 30%. So to your second question, which is this idea that MIBIC studies show that the greater the innervation that you have, the worse that you do, and yet we go ahead and we block the sympathetic nerves, and that seems to work well. There's sort of 2 points that I want to make, and one is that when you have myocardial infarction and inflammation and release of cytokines, the same process that kills those myocytes also affects the axons of those sympathetic nerves as well as parasympathetic nerve fibers. Now, these are all peripheral nerves, and their cell bodies are not damaged. So they're sitting in the cardiac ganglia or they're sitting in the stellate ganglion, and so they're going to try to grow back into the infarct because it's only their axons that are damaged. And so it is this abnormal innervation, re-innervation that tries to occur as a result of that seems to be what is arrhythmogenic. So obviously the greater the denervation that you have, the greater abnormal re-innervation you're going to have. And actually, Dr. Habeker's group has shown very nicely that in a mouse model, if you can re-innervate that infarct homogeneously, you actually can decrease arrhythmias. And there's proteoglycans and other CPGs that are produced that block that normal re-innervation of that infarct. Now, to the other thing I want to point out is that originally when we did the cardiac sympathetic denervation studies and looking at patients at UCLA, one of the things that we noticed, and this didn't reach statistical significance, the p-value was 0.1, is that a follow-up, they actually had an increase in EF, pre versus post-CSD. And so it's possible that cardiac sympathetic denervation is as not just by affecting the efferent fibers, but by also disrupting the afferent feedback that's going back through the nervous system, can prevent or improve heart failure.
I have one issue with that explanation, which is that the way MIBG scanning and other scanning works is based on norepinephrine reuptake being avid. And so you can't argue that nerve sprouting is compensating for the denervation, and then why does the MIBG uptake go? Is it
No. I'm gonna clarify that completely. So denervation is bad because denervation shows that your sympathetic nerve fibers are no longer within the scar. You no longer have homogeneous innervation. So it is the heterogeneity in your innervation that sets you up for arrhythmias. We can make stellate ganglion stimulation fibrillate normal hearts, but that's really at extreme levels. If everything was sort of innervated the same way as it had been before, we would not have that problem.
But in non-ischemic cardiomyopathy, the same relationships hold.
Yes.
And there it's a global denervation that you see that has a worse prognosis. And an alternative explanation that I just bring up for your consideration is what this norepinephrine reuptake system actually, there's some evidence that it may actually create a gradient between the norepinephrine that's circulating, the epinephrine that's circulating in the blood, and the amount that is actually seen by the myocyte at the level. So when you remove those sympathetic nerves in that reuptake system, essentially you now expose the myocyte 24/7 to a higher norepinephrine level. So then would be normal, and maybe that's that 24/7, constant exposure that is driving the adverse remodeling that occurs that's so maladaptive in heart failure. So,
well,
Question.
the same studies, and that's a good point, the same studies that showed the denervation of the infarct zone also showed something called denervation hypersensitivity. So I think that's the answer. I think the fact that, yes, those myocytes that are left in the border zone, yes, you have fewer nerves, but those myocytes are hypersensitive. I think that's...
Well, Dr. Knight looked at that question, and he determined it was not hypersensitivity, that they didn't find any evidence of upregulation of the G protein coupled signals or receptors that cause hypersensitivity of adrenergic receptors. So that's why, at least they postulated that it was this gradient that was protecting the myocardium.
Question from Dr. Zucker.
So this is quite a related question to this discussion. Years and years ago, it showed very clearly that there's a close correlation between plasma norepinephrine and survival in heart failure patients. Right, an old study by Jay Cohn many years ago. The question is whether or not coronary sinus norepinephrine would be a marker for patients with augmented sympathetic outflow from the stellate and could be used as a way of screening patients that would benefit from stellectomy.
Well, I can attempt an answer. I'd love to see what the panel says. We think that CS norepi may be more of a vascular control release, whereas what you find in the interstitium, and hopefully with Corey Smith's method, we'll actually find out what is actually measured. It can be done with catheters, we think, may actually tell us what really happens. And also partly to respond to Jim's question, what is not known is afferent sensing. And we think no matter what these MIBIC studies show, and there are lots of ifs and buts, it's unclear medicine, as people would say, nuclear medicine, and what it reads out. You see it in Parkinson's, many other conditions. But one way to solve this clearly is to get real measurements in the heart, and also look at what happens when you modulate afferent neurotransmission. So this whole concept of reuptake doesn't worry us so much because there are adequate nerve fibers over there. And we still do not know what the neuromuscular junction in the heart is. And there is a huge difference between junctional and extrajunctional adrenergic receptors. And where the reuptake transporters are physically located has not yet been established in the myocardium. So that is, as always, Jim brings up a great question. I think it can be answered, and maybe Olu and Hari and Pierre can make a comment on the extrajunctional.
Just to answer your question, I think the clinical relevance really comes in picking the right patient. How do you pick these patients? So who benefits from sympathectomy and not? At a macro level, at a patient level, there are clues suggesting who's sympathetically driven, who's not, and based on the circumstances in which their arrhythmia occurs. But it's also clear that there's a structural and functional component for arrhythmias. Otherwise, having a fixed anatomic circuit, every beat should lead to reentry. Every beat should be able to do that. It doesn't happen. Circumstances have to exist, and that probably is what the autonomic modulation is all about. It does help for us to do some autonomic challenging in the lab. We do a lot of catecholamine stimulation in the lab and probably put them on a treadmill before if they can do that. Many patients can't. Neural stimulation may be a way to figure that out. We've been trying to see how reliably do that in the lab because it's not possible to, we don't have catheters to do neural stimulation. But I think at that level, it'd be more relevant than actually trying to tease out the mechanisms at a cellular level because it'd be probably more applicable in a practical fashion. How do you, in the EP lab, decide who is sympathetically driven? I have some insights from right ventricular dysplasia itself, where we've been recording PVC burdens. And it's clear that early in the disease, there's a lot of PVCs in the day, nothing during the night. But as the disease progresses, the ventricle gets structurally more damaged. There's more structural component. There's more PVCs in the night, less during the day. When they're not sympathetically driven, they have a lot of arrhythmias too. So I'm not sure if in that you will have the same bang for the buck if you do a sympathectomy in those patients versus doing it earlier on. So there may be other clues that will emerge based on our clinical observations, but I think, I think, and if you want to chime in on, okay. So that, yeah, perfect. Does that answer your question?
But we have about a minute left, so if there are any remaining questions from the audience rather than me commenting, I can speak to anyone over lunch. Any questions from anyone else? Let me have Shiv and Jeff. Thank you so much.
Thank you.
Speakers. Now I'd like to have Jeff and Shiv come and give some parting remarks.
Thank you, Olu. So as Jeff walks up, again, thank you all. This is, for many of you, this is 6 years into this type of meeting every other year, and we've always done something to link to these meetings. Last time we brought out this dedicated issue of GFIS, And this year it's been fantastic having the NIH Spark grant. And when we meet in 2019, it's going to be the ISAN meeting. Please mark your calendars. The entire Luskin Center is going to be taken over for the ISAN Symposium. We're going to spill over to other hotels in this area because this hotel does not have enough beds, and they won't give up. I'm saying beds as a hospital. I should say rooms. This is what happens if you're constantly taking care of patients. We don't have enough beds. We can't get the patients in. No. Come here to enjoy your time. So, anyway, so at that, again, thank you all so much for coming and spending the time. We intentionally kept this meeting and let people go over their time limit because it's best to go with your natural flow. There's a lot of improvements that can be done in terms of instructions and what people should present, but then finding the right balance between what would be a garden conference and a most extremely structured meeting is always a challenge, but we welcome feedback. I think we ought to bring an autonomic neuroscience textbook for neurovisual sciences so that postdocs, it's all about the next generation. It's about the academic kids. So it's we want to make something good for the postdocs and grad students, and Jeff's vision is to work on that. So Jeff, if you want to say a few words, after that we get lunch and we continue spending time this afternoon, and thank you all.
Just my thanks, and realize in about a year and a half we're going to start bugging the heck out of you to help organizing Symposia for the meeting we have here in California. Go have a good lunch, and we'll see you later.
Thank you all.
Thanks.